Dear students, welcome to Bluepen Online. Shall we begin? Please use headset, pen and paper to take notes.
Here you go. Please let's know your feedback after class.
Today's the last class. Today's class is about anti-cancer drugs. Okay, it is a new topic. It's an emerging topic. So some questions are asked, but the questions usually asked are short notes. Okay, so I have taken the most important drugs and the most important points in each of them. Okay, so we divide drugs into two: cell cycle specific or cell cycle non-specific. Okay, cell cycle specific or cell cycle non-specific. Cell cycle specific or space specific drugs, okay, they act mainly on dividing cells. Okay, they act mainly on dividing cells. Okay, so these are antimetabolites, antibiotics, taxane, epipodophyllitoxins, and Vinca alkaloids. We'll go through each of these one by one. Okay, so antimetabolites, antibiotics, taxane, epipodophyllitoxins, and Vinca alkaloids are the main things. Okay, next one is cell cycle non-specific or phase non-specific drugs. Okay, they act on dividing as well as resting cells. Okay, so alkylating agents like cyclophosphamide, busulfan, meclorethamine, melphalan. Okay, anti-cancer antibiotics, actinomycin D, and methyl complexes. So there are two classes of both. Okay, another classification is major groups of anti-cancer drugs based on their structure and mechanism of action. Okay, so based on their structure and mechanism of action, they are divided into alkylating agents, antimetabolites, platinum containing compounds, natural compounds, miscellaneous agents, hormones, and antagonists. So these are all different types of classifications. First one was cell cycle specific and cell cycle non-specific. Second one is based on the chemical structure. Okay, and next one is toxicity of anti-cancer as cytotoxic drugs. So in cancer, what happens in cancer? A normal cell becomes abnormal, and this leads to proliferation. Okay, so basically these are our own cells. Okay, these are our own cells. So when you make an anti-cancer drug, it is against our own cells. So one second. Okay, so when we are making a drug against our own drug, there is a chance that our body gets lot of side effects. So one thing is general toxicity. Okay, bone marrow suppression. So bone marrow suppression, it manifests as leukopenia. So general toxicity means all drugs have these. Okay, all drugs have these. Bone marrow suppression is manifested as leukopenia, agranulocytosis, thrombocytopenia, and aplastic anemia. Okay, in such patients, infection and bleeding are common. Okay, it is ameliorated or reduced by platelet transfusion and granulocyte colony stimulating factor. Then erythropoietin, so platelet for platelet. This one is for WBCs. Then erythropoietin is for RBCs. Then you may have to transplant bone marrow, or we should use bone marrow sparing drugs like L-asparagine, bleomycin, cisplatin, and vincristine. So this can be a question. Okay, next one is immunosuppression. So here also they are acting against the body. Okay, they are acting against the body, and these these drugs may actually kill WBCs. Okay, they may kill WBCs, that is lymphocytes. So decreased lymphocytes will result in immunosuppression. Okay, such patients are prone to opportunistic infections with fungi, bacteria, viruses, and parasites. Okay, so these viruses are opportunistic parasites. Okay, so these are Plasmodium gyrovacii. Okay, Plasmodium gyrovacii, Candida, cytomegalovirus, etc. Okay, so these are the different infections. Then in GIT, it can cause nausea, vomiting due to central action, due to stimulation of chemoreceptor trigger zone. This one we studied in antiemetics. Okay, then cisplatin has a most emetogenic potential. Okay, 5-HT3 antagonists such as ondansetron and granisetron are the commonly used antiemetics. Other antiemetics are metoclopramide, and dexamethasone. Okay, then stomatitis, oral mucositis, diarrhea, GI bleeding, and ulcers are also due to necrosis of rapidly dividing epithelial cells. So there is basically any type of rapidly dividing cell will have these problems. Okay, so that is why we have all these manifestations. Next one is skin and hair. Skin and hair is also rapidly dividing. Okay, is due to damage to hair follicle. Alopecia or loss of hair is due to damage to hair follicles. Okay, it's usually reversible on stoppage of therapy. Then dermatitis and skin rashes too can occur. Okay, next one is gonads. So again, gonads have dividing cells. So they can cause oligozoospermia and infertility in males. Similarly, amenorrhea and infertility in females. Okay, in fetus. Okay, administration of cytotoxic drugs during pregnancy causes abortion or teratogenic effects. Okay, abortion or teratogenic effects. Then hyperuricemia. Okay, when there is excess cell production in cancer and these cells are killed by our drugs. Okay, killed by our drugs, there is a rapid cell destruction. Okay, cell destruction means DNA is also destroyed. Okay, the end product of DNA metabolism is uric acid. So there is hyperuricemia. Okay, this prevented by good hydration, allopurinol, and corticosteroids. So we have already learned this in drugs for gout. Okay, next one is hypercalcemia. It's either due to malignancy or anticancer. Okay, similar treatment. Okay, treatment is adequate hydration, bisphosphonates, and corticosteroids. Then carcinogenicity. This is very important. Okay, so drugs may rarely cause secondary cancers in some patients. So this is most commonly seen in leukemia. Okay, one type of leukemia may change into another during the treatment. Okay, so so because of this we are developing newer and newer drugs which has lesser side effects. Okay, then there is mutagenicity. Okay, next one is specific toxicity. So this is for one single drug having one side effect. So hemorrhagic cystitis. Hemorrhagic cystitis means there will be bleeding from the urinary bladder and there is inflammation. So here the thing is there will be blood in urine. Okay, blood in urine. Okay, so hemorrhagic cystitis. Then megaloblastic anemia. Megaloblastic anemia caused by methotrexate. Okay, then nephrotoxicity is caused by cisplatin. Then neuropathy caused by vincristine and paclitaxel. Then pulmonary fibrosis and pigmentation of skin by busulfan and bleomycin. Okay, then cardiotoxicity by doxorubicin and daunorubicin. Okay, so these are the specific toxicity. In this can be asked. Okay, this one is important. Okay, and this one is important. Mainly these two are very important. Okay, so first we are going to learn a first drug. Okay, so alkylating agents. Okay, alkylating agents, you have to know the names of alkylating agents. Okay, so alkylating agents. Okay, alkylating agents except platinum containing compounds, they form a highly reactive carbonium ion. Okay, they form a highly reactive carbonium ion. Okay, they will transfer alkyl groups to various sites of DNA. This results in cross linkage, abnormal base pairing, break in DNA strands and cell death. Okay, break in DNA strands and cell death. Okay, so you have to know the example. Example is busulfan. Okay, busulfan. Okay, then there is chlorambucil. Okay, chlorambucil. Okay, chlorambucil. So these are chlorambucil. Okay, so these are alkylating agents. Okay, then there is something called nitrogen mustards. Okay, so nitrogen mustards. So you just have to learn the mechanism of action. Okay, you just have to learn the mechanism of action. All these drugs, okay, they are used in different diseases. Okay, all these drugs, they are used in different cancers. So for you, what is important is the mechanism of action. Okay, next one is nitrogen mustards. Okay, so nitrogen mustards, the drug is cyclophosphamide. Okay, cyclophosphamide. Okay, cyclophosphamide. Okay, so cyclophosphamide is a prodrug. It gets converted into aldophosphamide. Okay, aldophosphamide is then converted into phosphoramide mustard. Okay, phosphoramide mustard and a toxic metabolite called acrolein. Okay, so I told you that cyclophosphamide can cause hemorrhagic cystitis. So this hemorrhagic cystitis is caused by this acrolein. Okay, so to prevent this hemorrhagic cystitis, we have to give mesna. So mesna will bind with acrolein and neutralize its effects. Okay, mesna will bind to cyclophosphamide and neutralize its effects. Okay, Then the uses are lymphomas, chronic lymphocytic leukemia, breast cancer, rheumatoid arthritis, nephrotic syndrome. Okay, it is also used to prevent as well as to treat graft rejection during organ transplantation. Okay, prevent as well as treat graft rejection during organ transplantation. Okay, then the next drug is cisplatin. Okay, so cisplatin is a platinum containing drug. Okay, platinum containing drug. So this platin means it contains platinum. So it forms highly reactive platinum complexes, reacts with DNA, and it causes DNA damage. This mechanism is very similar to that of alkylating agents. Okay, alkylating agents. The mechanism of action is similar. Okay. Then adverse effects are cisplatin is the most emetogenic anti-cancer drug, Okay, nausea and vomiting can be controlled by serotonin antagonists like ondansetron and granisetron. Then nephrotoxicity, okay, it can be minimized by proper hydration. Then ototoxicity with hearing loss with repeated doses. Then electrolyte disturbances. So these are all general things, okay, hypokalemia, hypocalcemia, hypomagnesemia. The neuropathy is common in higher doses, okay. It has mutagenic, teratogenic and carcinogenic properties, okay. Next one is folate antagonist, methotrexate. This thing we have actually already learned in rheumatoid arthritis. Okay, so it is a cell cycle specific drug and it acts during the S phase of the cell cycle. Anti-neoplastic, immunosuppressant and anti-inflammatory effects. So here DHFA is converted to THFA with the help of DHFR enzyme. It is inhibited by methotrexate. Okay, synthesis of purines and thymidylate. Okay, DNA RNA synthesis. So this is the mechanism of action of methotrexate. So it is given orally. Okay, it is well absorbed after oral administration. It can also be given IM, IV or intrathecally. Okay, it is bound to plasma proteins. It poorly crosses the blood-brain barrier and most of the drug is excreted unchanged in urine. Okay, this is drug of choice for choriocarcinoma, also used in acute leukemias. Okay, Burkitt lymphoma, breast cancer. So methotrexate is a drug with a lot of uses. Okay, then it is also used in rheumatoid arthritis. Okay, then for psoriasis, IBD and organ transplantation. So methotrexate is a very, very important drug. It can be asked from, like, it is there in it is there in different chapters. It has different uses. So it is very important that you learn methotrexate properly. And it is useful for your entrance also. It is useful when you go upwards also. Okay. Then purine antagonist. Purine antagonist, 6-mark capture purine and thioguanine. So our DNA consists of purines and pyrimidines. Okay. So they are antagonists. So it will like 6-capture purine gets converted to thiouric acid, and this thiouric acid will inhibit the DNA formation. Okay, it is used in acute lymphocytic lymphemia. Then pyrimidine antagonist. Okay, pyrimidine antagonist 5-fluorouracil. Okay, this 5-fluorouracil is activated by fluoridodeoxyuridine monophosphate. It is activated to FDUMP. Okay, FDUMP. This uracil gets converted to uridine monophosphate. It interferes with DNA synthesis and functions by inhibiting the thymidylate synthetase enzyme. Similar action. Okay. Then it is used in colorectal, upper GIT, breast and ovarian cancer. Okay. So it inhibits DNA synthesis. So when there is a purine or pyrimidine antagonist, okay, DNA synthesis is in there. DNA synthesis is inhibited. Okay, is inhibited. Then vinblastine and vincristin. Okay, the mechanism of action, they bind to beta tubulin. Okay, it binds to beta tubulin. It inhibits polymerization into microtubules. Okay, it inhibits the polymerization into microtubules. There is no intact mitotic spindle. Then cell division gets arrested in the metaphase. Okay, cell division gets arrested in the metaphase. Okay, so there is vinblastine and vincristin. Okay, the uses are Hodgkin's disease, carcinoma, breast, testicular tumors. Okay, toxicity is bone marrow suppression, anorexia, nausea, vomiting, and diarrhea. Okay, in vincristin, leukemias and tumors, childhood leukemias and childhood tumors. Then toxicity, peripheral neuritis with paresthesia, constipation. Okay, it has minimal myelosuppressive action. So in children, vincristin, because of this specific point in children when Kristen is preferred. So C has in Kristen. Okay, Kristen has C and C is preferred in children. Like that, you can remember. Next one is taxanes. Okay, taxanes also have similar action. Okay, so they bind to the beta tubulin. They stabilize microtubules, formation of abnormal microtubules, and inhibition of meiosis. So, mitosis. Okay, so here also the beta tubulin is inhibited. Okay, and the cell cycle thing will be arrested. Okay, cell cycle mitosis will be arrested. So it is a cell cycle specific drug. Okay, it is used in breast, ovarian, esophageal and bladder cancer. Okay, blob, breast, ovarian, esophageal and bladder cancer, and lung also. Okay, unwanted side effects are bone marrow suppression, peripheral neuropathy, myalgia, and hypersensitive reaction. Okay, so then you have to learn some. So this anti-cancer drugs chapter is over. So these are the different drugs. You have to learn the classification. Classification means you have to know which one is cell cycle specific and cell cycle non-specific. Okay, then you have to learn the drugs one by one, and then most important is methotrexate. Then cyclophosphamide is important. Okay, methotrexate is important. Cyclophosphamide is important. Taxanes can be asked. Okay, so these are the main things. Okay, next we move on to other things. So this is an iron chelating agent. Okay, chelating agents, iron chelating agent. Okay, so desferrioxamine. So desferrioxamine can be given IM or IV. Okay, it is given for chronic iron poisoning. Okay, chronic iron poisoning, IM, and for acute iron poisoning, it can be given IV. It has low affinity for calcium. Contraindications are pregnancy and renal insufficiency. So this is a very small question. Okay, chelating agents can be asked. Okay, in this is a very small topic. In that, sometimes this can be asked. Okay, so chelating agents, it is usually used in. It is actually usually used in what in it is used in especially thalassemia and all. Okay, when the patient receives repeated blood transfusion, or it can be hemochromatosis. Okay, hemochromatosis. So these are the different conditions where there is increased body iron. So example is desferrioxamine. Then another drug is deferriprone. Okay, deferriprone. Okay, there is deferriprone. Then there is deferrasirox. Okay, so these are the different drugs. Okay, next one is D-penicillamine. Okay, so D-penicillamine is used for copper, mercury, and zinc and lead poisoning. It is also used in Wilson's disease. Wilson's disease is copper. Okay, copper deposition, scleroderma, cystinuria, and rheumatoid arthritis. Okay, so these are the. So that is the whole second year pharmacology for you. Okay, I want.